Thank you for joining our June special edition Coffee with Coher, a panel discussion on MACRA. As always, it's a privilege to have you join us. After the presentation, if you would like more information on the topics discussed and how they affect your organization specifically, please reach out to me directly at sburnett, B as in boy, URNETT, at cohergroup.com, and we will coordinate a time for a customized presentation for your organization. We'd also like to mention that we will be launching a separate webinar series specific to the capabilities that will help providers successfully navigate the path from volume to value. The dates for this program are not finalized, but will be posted on our website, sent out via email. Please be looking for this information. For today's panel discussion, we will have an extended question and answer period, so please submit your questions throughout the presentation in the area provided in the GoToMeeting dashboard. The participant phone line will be muted for today's presentation, and the materials will be emailed to you shortly after the conclusion of the session. Finally, as you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation as well as suggestions for future topics. Our panel today includes Max Reibold, President and CEO, Dr. Mac Knight, Senior Vice President and Chief Medical Officer, Amy Greeter, Senior Vice President, and Terry Wilk, Senior Vice President. Please join me in welcoming our panelists.
So good afternoon, everybody. My name is Mac Knight, and as Savannah mentioned, I'm the Senior Vice President and Chief Medical Officer at Coher Group. We are going to do a fairly rapid run-through this afternoon of the MACRA and its subcomponents, MIPS and APMs description for you, and order to try to get everybody up to a baseline level as we proceed into our panel discussion and our question and answers. So I hope most of the information I'm going to cover here first is not too elementary for everyone. I'm sure you've all been bombarded with lots of information on MACRA, but hopefully this introductory set of slides will get you all to a baseline understanding that we can then expand on through our panel discussion. So let's start by talking about the impetus for MACRA and where this really started. And to do that, we have to go back to April of 2015, or excuse me, January of 2015, at which time Sylvia Burwell, the Secretary of the Department of Health and Human Services, came forth and made two very broad goal statements which really triggered much of the MACRA and other move towards value-based reimbursements in the Medicare system that we're seeing today. The first statement was that Medicare physician payments were going to be tied to value through alternative payment models, and we'll talk more about alternative payment models as we go through this session. But the goals set by Secretary Burwell in January of 2015 were to have 30% payments through those models by the end of 2016 and 50% by the end of 2018. The second goal statement stated that total Medicare payments would be tied to quality or value at a rate of 85% by the end of 2016 and 90% by the end of 2018. I will tell you that many of the clients and many of the individuals that I talked to back in 2015 really had doubts as to whether this would come to pass. But I think in 2014, with the advent and passage of the Medicare Access and CHIP Reauthorization Act, or MACRA, we all became true believers. The act passed in April of 2015. We got the notice of proposed rulemaking issued in April of this year, and the final rule on this piece of legislation is expected in November of 2016. As many of you know, this act replaced the sustainable growth rate, which was found to be a very flawed mechanism to control payments to physicians and sustain the growth rate and the cost curve within the Medicare system. And it replaced the SGR with the topics that we're going to talk about today, namely MIPS and alternative payment models. The other thing that's very important to recognize is that MACRA consolidates multiple pre-existing reporting and payment programs, and these programs, I will emphasize, will continue at least for the next 2 years while MACRA data is being captured and the MIPS program is waiting to go into full effect in 2019. But for those of you who have been participating and are well familiar with the PQRS system, with value payment modifiers, and with meaningful use, those will go away after 2018, but for the next 2 years, those things will still be in place. The MACRA legislation, again, also included a new payment system, the merit incentive payment system, and expanded upon an alternative payment model that we had become somewhat familiar with in the past through Medicare ACOs, but really expanded on that and pushed things along in that direction, more so in sync with the goals expressed by Secretary Burwell in 2015. So let's take a look first at MIPS, or the Merit Incentive Payment System. Again, this will go into full effect in January of 2019. It will reward physician performance via a 2-year look back. For an example, in 2017, when the performance data tracking starts, that data will determine payments for 2019, and it will be a 2-year look back from then on. Eligible participants in the MIPS program right now, starting in 2017, include physicians, dentists, physician's assistants and nurse practitioners, clinical nurse specialists, and CRNAs. In year 3, i.e. 2019, other participants will become eligible to participate in MIPS, including rehab professionals, audiologists, nurse midwives, social workers, clinical psychologists, and nutritional professionals. The ineligible providers to participate in MIPS include those who are in their first year of participating in Part B of the Medicare program, those who bill Medicare even if it's not their first year, less than $10,000 per year, or those who care for 100 or fewer Medicare patients per year, those who are participating in an advanced APM, and we'll talk about that and define that more in just a sec, and hospitals. I recognize that many on the call today are hospitals, and I would emphasize that while Medicare Part A is not affected by MACRA or MIPS, certainly Medicare Part B is, and therefore many employed physician networks of hospitals will be participating in these programs and will need to know this information. The way that MIPS works is that performance measures are tracked across 4 broad categories, and performance in each of those categories is then used to create a composite score for individual providers. The 4 categories are quality, and that will be built on the PQRS quality reporting system that's already in place. Secondly, resource use, and that will be built on the value payment modifier system that's already in place. Third will be clinical practice improvement activities, or what are called CPIAs. And then lastly, advancing care information, which really replaces the meaningful use criteria that we've been dealing with for the last few years. As you can see, each of these categories are weighted differentially, and the quality rating is the highest, and then the smallest piece is for resource utilization. The payments from the MIPS system will be made so that this program can remain budget neutral. Make no doubt, Medicare is looking to this program to sustain the growth of their spending, and they will particularly adjust things to make sure that the overall spend is neutral and not increasing. The way they will do that is that they will set the payment threshold so that 50% of the providers will get a greater reimbursement and 50% will receive a negative adjustment in their reimbursement. And if the numbers need to be adjusted to remain budget neutral, they will adjust those getting a higher threshold so that, again, it will exactly equal those getting a lower adjustment and equal out and remain budget neutral. In addition to those basic adjustments, which as you can see starting in 2019 range from a plus or minus 4% adjustment up to plus or minus 9% adjustment in 2022, there may also be exceptional performers, which I will tell you they have not yet defined, who may receive up to a 10% upward adjustment in payments, and that upward adjustment is outside of the budget neutral component of this program. In addition, as mentioned already, if there is a need to make sure that the 50-50 split between upward adjustments and negative adjustments exist, the upward adjustments may be multiplied by a factor of 3 so that they can maintain budget neutrality. Finally, MIPS providers who are in an alternative payment model but nevertheless still opting to participate in the MIPS program may receive an additional increase in reimbursement of 0.5% at least up until 2020. So let's look at these mysterious alternative payment models. An alternative payment model basically comes out of several programs, many of which you may be familiar with from CMS. The first is an innovative payment model, an expanded innovative payment model under the Center for Medicare and Medicaid Innovation, or CMMI, and that's with the exception of Healthcare Innovation Award recipients. Second category is a Medicare Shared Savings Program, which I'm sure many of you participate in today. However, most of you are participating in Track 1 MSSP programs, and those will not be considered advanced alternative payment models by the time that this goes into operation. The third category is Medicare Healthcare Quality Demonstration Program, or the Medicare Acute Care Episode Demonstration Program, or any other demonstration program which is required by federal law. So what really kind of ties all these APMs together, and what are some examples that we can give to show you what some of these will be going forward? First of all, each APM must use certified EHR technology. Secondly, they must base their payments on quality measures that are comparable to those used in the MIPS payment system. Third, they must have at least one outcome measure, this as opposed to process measures. Fourth, the participants in these APMs must bear risk, and it must be more than nominal financial risk. And again, of course, that is yet to be accurately defined. And some examples of advanced APMs, at least in the first year, in 2017, will be Tracks 2 and 3 of the Medicare Shared Savings Program, the Comprehensive End-Stage Renal Disease Care Program, the CPC Plus Primary Care Program, and the Oncology Care Model, which at least by 2018 will have a two-sided risk track, i.e. upside risk as well as downside risk. Furthermore, on APMs, in 2021, CMS will start including other payer APM models and bringing them into the system so that if a provider is participating in, for instance, a commercial payer ACO model, depending on whether that APM or that ACO meets CMS criteria, which again are use of the certified EHR, required quality metrics, and financial risk, then those providers will be allowed to be considered exempt from MIPS and participate in those APMs, even if they're sponsored by a non-CMS payer. Last but not least, the payments for APM qualified providers will be quite different. The payment mechanism will be quite different than what I outlined earlier for MIPS participants. The APM qualified providers will get a 5% bonus payment from 2019 through 2024, and then in 2026 they will start getting an increase on their fee schedule of anywhere from 0.25% to 0.75% per year, depending on budget and available funds. So that is the conclusion of our very high-level, quick run-through of MACRA and MIPS. And at this point, I'd like to turn it over to my colleague, Amy Greeter, who will talk to you about how MACRA fits in with alignment and integration activities. Amy?
Terrific, Mac. I appreciate that. And I appreciate everyone being on the line today. As Mac mentioned earlier, we're confident that you're being inundated with information relative to MACRA at this point. We appreciate you spending some time with us and allowing us to participate in your education. So as Mac said, I'm going to talk about MACRA and its relationship to alignment and integration. And when we talk about alignment and integration, we talk about it as not synonymous terms, but rather as a sequential and stepwise process. So the way that you'll hear me talk about alignment is more of the structural alignment opportunities that exist between physicians and other physicians and hospital partners. And then integration is a deeper look at true clinical integration. So moving beyond the structural processes and looking at ways that are really impactful at the clinical and to some extent operational level as well. So let's look first at alignment. One of the things that we are repeatedly asked as a firm, and certainly I am as well, by past and current clients, excuse me, is now the time to align? So we've had this revelation about MACRA. Everyone's sort of treading lightly until we find out what the final rule to be released in November will bring. But if we are not aligned, is now the time to do that? And that's being asked by both our private practice clients, our medical groups, as well as our hospitals. So our physician practices are saying, we've been at it a while, we're successful, we're relatively successful in private practice, but being successful has come with greater challenges in the recent past. And is MACRA going to be the next challenge that really puts us over the edge in terms of being able to be successful on our own? And likewise, our hospital clients are saying, is this the opportunity where I should really look to solidify my relationships with my practice base? Is MACRA the impetus that I need to really look more aggressively at partnering with physicians? And so the answer that I would have to both parties is that while now makes good sense to look at alignment, you shouldn't feel like MACRA is essentially forcing you to align. So there is not anything in the legislation that mandates that physicians have to align with larger number of physicians, or hospitals have to align with their physician base. There's just nothing in the legislation that mandates that. Now, from a strategy perspective, that may make a lot of sense. So, for example, for our private practices, those practices that are struggling right now to do more with less may find that now is the right time for them to align, that it does make sense for them to go ahead and look at a partner that will help them with the resources that are needed to, that are necessary to carry them forward. So one of the interesting surveys that came out in Becker's, I guess it was 2 weeks ago, last Monday, was a survey of 1,300 physician groups. Of those 1,300 physician groups, 67% said that they do not have the technology, capital, or staffing required to comply with the MIPS aspect of the MACRA legislation. In addition, 78% of independent primary care physicians said that they plan to either join with another physician group or with a hospital system in the next 3 years to make sure that they can continue to be successful. So at least this survey is telling us that the majority of folks in private practice that were surveyed do not feel confident in their ability to be self-sustaining going forward. And if you are in that boat, if you really feel like you don't have the access to the resources necessary to be successful, then I would say yes, now is the time for you to continue to look at alignment. The one caveat I will give you is that alignment means a lot more things than just employment. So if you're considering alignment in your practice, think about what alternatives, or educate yourself on what alternatives exist to just employment, because there are a lot of opportunities that you'll be missing if you put yourself on a single track mind just to employment. The next point that I wanted to talk about, one of the other big questions that were asked is, if you're already aligned, so not if you're thinking about being aligned, but if you're already aligned in some way with a partner, what's going to happen now as a result of MACRA? What changes can you expect? Are you all of a sudden going to find that the deal has to unwind? Is there going to be no execution of a second round after your initial term is up, for example? Are you going to see drastic changes in renewal terms? Are you needing to make those changes in your renewal terms if you're one of the partners? And so I think the biggest change that we will start to see in terms of the already aligned relationships is relative to the existing compensation plan. And I know Max Reibold is going to talk about that in another slide or two, so I won't steal his thunder. But there are going to be some necessary changes that should occur, again, from a common sense standpoint, as well as just a reasonableness standpoint based on MACRA to compensation plans. So we'll let Max dive into that, but know that there will be changes that will come, but of those, the most substantive to current alignment relationships is likely to be relative to compensation. Next, I want to talk to you a little bit about MACRA and integration. So we talked to you about how alignment is a structure. Integration is more of that focus on clinical integration and how do things change in the way that providers deliver care to their patients at the bedside, in the exam room, etc. And so some of the things that we're looking at are, what are the challenges that exist relative to clinically integrating providers? And there are a couple. I will say that it is not infrequent that I either come across a physician or I'm told a story about a physician that likes to do what he or she does in the way that he or she does it and doesn't want to change. It's not that there's a pig-headedness, it's just that they feel very comfortable in the way that they practice. And so there isn't a need to practice in accordance with some standard. One of the things that we struggle with is that when we look towards clinical integration at a systemic level, there has to be a greater sense of providers practicing to best practices, and that can often mean some changes are necessary to conform a little bit more to that uniformity. And there's still plenty of opportunities for practicing individual medicine, but there are best practices in place for a reason. And so one of the challenges we see is how do you really develop and then implement and then hold people accountable relative to that practice of medicine in which there is a bit more uniformity than has been seen previously. So that's one of the greatest challenges that we see. One of the other challenges that we see relative to clinical integration is providing appropriate incentives for providers. And so if you want to drive a certain behavior, one of the old arguments is that you put in incentives that will push the behavior in that direction. And so making sure that we understand what reward systems are in place or what punitive systems are in place to really drive the level of integration that is desired can be something that requires a bit more foresight. Finally, I want to talk to you about the structural models. So it is true that MACRA does drive alignment in a way that favors certain models, like medical homes or ACOs, and you can see that obviously in the APMs methodology very clearly. And so one of the things that we need to think about is if you are not currently pursuing one of these models, such as a medical home or an ACO, now is really the time to start thinking about that and thinking about how you use it to respond to MACRA, but also to really help drive the clinical integration that's necessary for you to be successful under MACRA. So we can talk a lot. I could talk ad nauseum about both of those models, medical homes and ACOs, but certainly just wanted to make it clear that there is a very real opportunity and an incentive under MACRA for there to be an increased level of clinical integration, and obviously that level of clinical integration can be met through a variety of structural models, with some obviously being more natural and lending themselves to that portent as well. Before I run away with any more of his thunder, I'm going to turn it over to Max Reibold, Coher's President and CEO, to talk about MACRA and the relationship to contracting. So Max?
Thanks, Amy, and good afternoon. It's a pleasure to join in this webinar, and I've already learned some things, and I hope you have too. So let's delve into further this discussion, as Amy alluded to, on contracting. So a couple of things I want to say at the beginning, and as we move to slide 16 and talk more specifically about value-based payment methodologies, I think there was a couple things that have been pointed out earlier that are relevant to this discussion, these slides I'm going to share with you. The first is that ideally, if you want to call it that, in this whole structure of this legislation and this law and the actual interpretation thereof, the reimbursement, in other words, the way we're paid, is going to change a great deal. We usually use the term shifting from volume to value, and of course that's not 100% the case where it's 100% shift from volume to value, but certainly a significant amount. But I think the thing that's interesting, and of course we are talking about the government reimbursement here, in this case, that it is essentially budget neutral. So there's not a whole pot or any additional money that's going to be available that is going to be added to or in addition to what is being paid under the present system once, in fact, this takes full effect. So I think that's important to note that as we look at new types of reimbursement or payment methodologies, that the dollars are not going to get any larger. Now, that's not exactly the case in the past. There have been threats, if you will, of cuts, and in some cases there have been some. But for the most part, the SGR has really entailed some net increases. We could argue as to whether they were enough to even offset inflation or cost of living, if you will, but nonetheless, for the most part, they've had some small increases, and when you compound those year upon year, it's certainly more over a span of time. In this case, they're making it pretty clear that this is not the case. So it's incumbent upon us as we develop our strategies, and you know, this is really what this is all about. We can interpret the law all day long, and we can read the rules and try to follow them and get outside assistance to the extent that you need it, and internal assistance to the extent you have it, and do a pretty good job, I think, of interpreting it. What really comes down to the real key of whether or not we can navigate through this change successfully is how we as individual organizations respond to it and deal with it, and ultimately not only continue hopefully to deliver high quality of care, but do so at an acceptable economic outcome. So as it relates to the different types of payment methodologies, the ones that are listed on this slide, which I don't need to go over them in detail, are commonplace. They are things that have been around now really since the passage of the Accountable, or I should say Affordable Care Act. And so these aren't new, and my guess is most of you probably are pretty familiar with them. Shared savings, quality incentives, bundled payments, etc., and indeed even partial and global capitation. Medicare Advantage, for example, has had a capitated plan on primary care for some time, and in fact many physicians, many primary care physicians, have done extremely well within that model. So I guess the point I would leave you with here from a strategy standpoint on payment methodologies is that yes, it is going to be different. It is going to take some education and training of our providers so they understand the differentials and the things that are different. It's not business as usual in this what I call new world order of reimbursement. In other words, the mindset will have to change. It has to require better coordination of care because we're in this together in consortiums, whether they're CINs or enterprises within a health system, etc. And so we are going to have to adapt to these changes. You know, yesterday I was working with an OBGYN group and we were doing some strategic review, and one of the slides we shared, and I'm just going to very briefly use it as an illustration here, was a bundled payment example of a normal delivery. And this is actually put out by CMS. So not that you're going to remember the numbers here, but the components of the bundle that CMS has put out relative to a normal delivery of a baby includes the hospital charges for the mother, needless to say, the routine obstetric care during the prenatal period, the hospital charges for the baby. So we do technically now cover, you know, the OB side, but possibly even part of the pediatric side, anesthesia, lab, prescriptions, radiology, and vaccines and other preventative care. Now that bundle, for what it's worth, in the numbers that we have researched, totaled about $7,540. We don't have time to dissect that now as to whether or not that's good or bad, but I can tell you what it is, and that is it really encompasses literally all of the players, or virtually all of the players that are involved both pre and even at the time of delivery and shortly thereafter for the normal delivery process. And that's the kind of thing that we're going to be faced with going forward, is exactly how do we divide up that money, how do we really live within those parameters. And MACRA, and specifically the MIPS requirements, are going to require that sort of thinking. Now, the other thing that I think that's going to require is, and Amy alluded to this, earlier is some revisiting of our physician compensation models. We are already within our consulting group and specifically within that area of expertise working with health systems, the physician compensation model in an employed setting. We are moving ever so progressively, I guess is the way to put it, towards something other than, quite frankly, particularly those hospitals that if you're not already looking at your comp models and making some changes to at least include a portion of the total compensation pie to something based other than productivity and most likely some sort of a quality-based incentive, you should be doing so. Moreover, you're going to pretty much have to do this once this law takes effect. Now, since the reporting starts as soon as next year, I would submit to you that you really shouldn't wait too long. And obviously, as we drill down on this, we'll provide more and more information to our clients and others that are interested through these webinars. And in fact, I envision a specific webinar only devoted to changing physician compensation plans under this new payment model. So these are things that are extremely important to remember as you strategize on how to deal with this legislation. Going to slide 16, or excuse me, yeah, that's right, we're on the next slide. Forcing the providers to prepare. This is really what I've been talking about, and I think the order of the day, if you're not already doing it, is data, data, and more data, and making sure that it is aggregated and coordinated across the consortium, whether it's your health system that essentially is a closed system that employs or has some sort of contractual relationship with virtually every provider, or whether or not you only employ a few and you are contracting through a clinically integrated network, which I think would fall with most of you. If you are a private group and you want to remain private, then I would submit you're probably going to need to find a partner in some form or another through a CIN like Amy was talking about earlier. The key here is coordination of care and lowering cost or keeping cost under a certain amount so we can have better results financially, if you will. This will require strong data accumulation and aggregation, and as we say here, a comprehensive strategy as we move away from strictly the volume thinking. One other thing that I alluded to that I'm going to emphasize yet again right now, and that is we're going to have to really work with our physicians and other providers. They have been trained, for the most part, with some exceptions that are involved in capitation, but they've really been trained to certainly not overutilize, that's inappropriate and even unethical, but certainly from a mentality standpoint, they've been trained to, when a procedure is needed, to do it, and that's the way you get paid. And really with very little coordination from one provider or one department to another. Those days are gone. They have to change, and we have to work toward a different mindset altogether. So really, as we look at some of the more advanced APMs on the next slide, slide 18, we'll go there, Mac. Yes, thank you. The specific programs are there, and these are referred to as the advanced alternative payment models and are indeed alternatives to MIPS. And most of the clients that we are working with at this point are really looking to these alternative models. I think it was, quite frankly, good of the government to allow this, to not make it so rigid that you have to live with their requirements for MIPS, and that there all are alternatives to those. Now, with that said, it does take some specific thought and planning and conformance, if you will, We've given you some examples of these here on this slide, as some of them are very specialty specific and then others are more general. The Medicare shared savings programs, and Mac pointed this out and I want to reemphasize it, for those of you that are involved in Track 1, which is probably most of you if you've been involved, that won't apply. That does not qualify as an alternative to MIPS. However, Tracks 2 and 3, which are a little more laborious to go through and navigate and become involved with, but they do apply. And what we foresee is, as time goes on, that most likely virtually all the specialties, we've listed primary care, nephrology, dialysis through end-stage renal disease programs, and of course cancer care as examples that have already come about. But we believe that virtually every specialty and certainly even subspecialties will develop some of their own alternative payments, or alternative to MIPS, I should say. So I think there is definitely good opportunity here. I'll just close my part of it by giving you an example. I recently spoke at the American Academy of Orthopedic Surgeons conference, and Amy and I did, and what was interesting there is that the orthopedic group, and in their practice management section, was really progressive in their thinking about how to navigate through the bundled reimbursement, the CJR program, for example, and the BPCI program even before that. And the net of that is, if you have your data and if you, quite frankly, understand how to deal with the negotiation of a bundle with your quote-unquote partners, you can come out very well. And in fact, maybe the reimbursement could be even better than it is under a fee-for-service environment, at least within the allocation of bundles. In this case, of course, they were focused on the surgeon. So for the hospital folks on the call, you have to be savvy to that as well. So clearly there's a lot to consider relative to contracting and how we're going to be paid going forward. We can choose to collectively kind of keep our heads in the sand on this, or we can be more aggressive and realize that it is reality, it's going to happen. I always say it's apolitical. It doesn't matter who's elected, I believe, because I think this MACRA is here to stay. I had a question recently, does MACRA, if the Obamacare Affordable Care Act were repealed, assuming a different party was in the White House along with the Congress next year, would that change MACRA? Well, of course I don't know that, but I would give the opinion that it's highly unlikely, that MACRA is here to stay, because I believe the principles surrounding affordable care, accountable care, however way you choose to call it, value-based reimbursement are here and are certainly averse to politics. So with that out of the way, let's shift to something else that is extremely important, albeit essential, to navigating through this whole MACRA MIPS issue, and that's the information technology that's required. So our Senior Vice President, who helps be an integral part of our technology consulting, Terry Wilk, a former CIO himself with a hospital, is going to share a few thoughts along those lines with us. So Terry, take it away.
Thank you, Max. And again, I welcome everyone as well for taking time out of your busy schedule to learn along with us about MACRA and all the implications of it. What I want to focus on in the last few slides, and I'm kind of the cleanup guy here, finishing up at least the formal part of this presentation, I want to kind of bring some thoughts together on IT and the implications of IT for MACRA, and based on what you've learned, what you knew prior to this webinar, what you've hopefully learned today as your knowledge grows, and really focus in on IT. If we can go to the next slide. As a reminder, what all of this is about at the end of the day is we want to be able, as providers, to show that we are bringing a higher value of care to our patients, our customers, at lower cost. So if we just fix on that one principle, very important going forward in my presentation here. when CMS, on the next slide, when CMS began conceptualizing this whole strategy of reimbursement change, they said, you know, we want to create some very clear strategy goals related around quality, and I've summarized the 6 of them here for you. And these probably are not, these are things I'm sure all of you are dealing with or have talked with, but just again to reorient ourselves. We want to make care safer, what we do in our organizations, what we do for and to our patients. We want to make sure that our providers, from CMS's perspective, engages the patients and their families and look at how we can create care partners, if you will, with them. We want to strengthen that. Certainly the communication and coordination that Max and Amy and Dr. Knight had already talked about, we want to promote that going forward. We want to move from sickness and illness to disease prevention and treatment. And hopefully, as we do those things, do them with more effective results at less cost. We want to work with communities to promote healthy living. And what that means is the communities that the patients are in. It means the people that are a part of the care team, the physicians, the hospitals, you know, those kinds of parties, as well as making care affordable. So from the perspective of the CMS, these are kind of the key drivers, these goals. Then they took the next step, if you will, and began defining a a measurement data plan, or MDP, for how they're going to guide the development of these measure sets or the types of metrics that they're going to be developing. And what they want to do first and foremost is make sure that as they put out these new requirements of metrics, or merging in requirements from PQRS, meaningful use, and so on, they want to make sure they align with these 6 quality strategy goals. Focus on performance and outcomes, not processes and activities. That's really a shift, as we've seen in the meaningful use criteria. For example, stage 1 was simply checking the box that you did this, you did that, you're capturing this indicator, and as it progressed now to stage 3, it is highly focused on performance and outcomes. Seeking community input, again, from the different people that have to provide the data, the physicians, the caregivers, the hospitals. Is this realistic for us to implement the requirements for capturing this kind of data that we want to begin monitoring? And if we can hit these targets, we believe that care will be improved at lower cost. There's also a tenet to incorporate evidence-based medicine, which has been around a long, long time, and now for real, bringing it in as part of measuring how well an organization or a provider is using empirical evidence to guide what they do on a day-in, day-out basis to help manage risks, improve outcomes, and so on. Another aspect, a guiding tenet, is to prioritize the electronic data sources. Of course, the government does not want anybody to go backwards in their use of technology, and so that's where the meaningful use, for example, is going to be rolled into this with EHRs, patient registries, other types of IT systems and data sources that need to come together. And then also they're going to include in these measure sets a factor of risk adjustment based on patient demographics. And so that's kind of the guiding tenets that they're using as they're developing these measure sets. So the way I think of it is really quality metrics really become the very backbone of MACRA. And what this has to do, one key takeaway is all of us need to realize this is going to take our data collection, our measurement, and our reporting to whole new levels that we cannot necessarily do with just the technology we have in place. And frankly, what I've seen and what we've seen interacting in hospitals and different provider environments, physician offices, we spent a lot of time and effort and money on transaction-based systems, scheduling a patient, registering a patient, ordering a test, posting a result, generating a charge, generating a bill, all these individual transactions. And we have some pretty good systems in place, and hopefully our workflows map those systems pretty well. But now we've got to work on how do we take all of those transactions that are happening, step up a level, and look at our data in a new way. And so what I thought I'd do in the next couple slides here real quick is just look at a little more deeper look on the implications of IT as it relates to MIP and then APMs. Under here, and again, if you would, put your data glasses, your IT glasses on as you look at this. When you really realize what MIPS is doing, as Dr. Knight had presented early on, we're consolidating 3 different disparate Medicare quality programs, and you see the 3 listed there, into one. And there's now 4 new performance categories from these 3 programs, and they're focused around the quality, which are going to be measures that are right now targeted to be selected annually. So and reporting on today, but what's coming down the pike, so we got to pay attention to that. Advancing the care information, that's what the EMR incentive program, meaning more of the connected care. It's more simple. We can connect patients to the information that is theirs, that they can securely access. And then the clinical practice improvement activities that Dr. Knight talked about, that deals with workflows and how clinical decisions are made and on what data and the timing of them and what's the outcomes of those decisions. And then, of course, how much utilization it is taking of supplies and other and resources to, which leads to costs to provide that level of care. With MIPS, as we've heard, the measurement is going to begin in 2017, and folks, that's just 6 months away. And if you haven't started thinking about these IT implications, boy, you really need to jump on that right away. And I've got a conclusion slide that has some suggested next steps for you. But that's not a lot of time at all, especially when you have vendors and other customers of theirs that are also putting demands on them to address their needs. And then, as we heard in 2019, the first payout based on 2017 results. So when you think about all of this, the implications, we cannot do it without data, without IT, and IT infrastructure, meaning secure networks and reliable systems that are available. As we go to the next slide, the implications for APMs, similar kind of a thing here that's heavily relied on metrics. There's 3 new performance categories: promote payment incentives for higher value care, addressing the care delivery improvements, and then making information more available. Some of these things are related, but again, how are we going to measure to know we're going to be doing these things? Well, this is where the CMS is developing these measurement sets based on those goals and those tenets that I reviewed earlier. And then the advanced APMs, just to be clear, they must meet, to be considered an APM, meet these 3 requirements of using the certified EHR. Their payment will be based on comparable quality measures, and as we discussed earlier, taking on more risk as a medical home or other forms of taking on more risk for losses. So, as I thought about this, and as I'm looking at this as a physician, let's say, these are some key questions that I believe that we are talking with our clients about when they ask us about this to help them. First of all, what data is really required to track and report each quality metric? And you may say, well, we're not really sure what all those metrics are. Well, they are developing them, but what we do know is the PQRS, we do know the meaningful use, we do know some other things that we track. Do we know what data that we have to capture? That's one key question. And don't just assume, oh yeah, somebody knows that. I'm talking about really understanding it. Then asking, are we capturing this data today in some IT system? And then, well, if we are, where are we capturing it? How are we capturing it? And who is capturing it? And if we're not, who should and how should we and where should we capture it? I mean, it sounds very simple, but if you work backwards saying, okay, we got to report on these metrics, we need to think about working backwards to the very source of where the data is obtained or where it should be obtained. And then if I am capturing this data, then another question is, what degree of confidence do I have in the quality of that data? Example, we found in one office, they had a very robust EMR, and they were putting in a notes field, a free-form notes field, of blood pressure and vital signs. Well, yeah, they're documenting it in the record, but they're not documenting it in the right place. so that they can report history over time, a patient's blood pressure or vital signs, for example. Another practice is putting it in the right field, so they're obviously able to monitor that. It's getting down to that level and not just saying, yeah, we're capturing the data, but is it accessible? Can it be added and subtracted and multiplied and divided, whatever is needed, with other data so that we can calculate metrics? Or do we need to step back and look at how we're capturing it, where we're capturing it, if even at all? Once we get some definition there, then what do we need to change in our IT systems, meaning IT configurations and our workflow? What I mean by configurations is, well, if we're capturing the data, where are we capturing it? Is it on this screen or that screen? Is it the registration? Is it the nurse that's capturing it? If we're not capturing it, where should we be capturing it? Do we need to change what's commonly called our templates, the screens that people go to click and point and enter data? Do we need to modify those? Can we do that? Does the vendor need to do it? Is there a cost? And then, oh, by the way, if we say we're going to start capturing this data and codifying it maybe on this screen, well, what about the training of people? And what does that mean for workflows? And is that person that's going to enter the data relying on somebody else to get them that data? I mean, it's things like that that we really need to look at if we're going to understand it. Then, assuming you got that under control, are you really ready? Is your practice ready to plan and implement the changes to the IT systems and the workflows, including the training and the testing and all of that needs to happen? Do I have the right tools, meaning the IT tools to go in, and the competencies in place? Like in analytics, for example, I had mentioned we have pretty good transaction-based systems, but now we need something to sit on top of that these data in an organized, secure way can go into, let's say, a data warehouse, and there's some analytic tools that are theoretically easy to use that somebody has to learn and take time to use to be able to go in and massage the data, look at the different slices and dices to really see what's going on in the practice. So you have people that are trained or that can be trained. Are you satisfied with the functionality and reliability of your current systems? I think we're finding a lot of people are questioning, man, this is so cumbersome to use, a physician with their EMR, for example, or, you know, the system goes up and down, it's not available, we got to go back to paper, and then when it comes back up, we've got to take all that, the information we put on paper, re-enter it in the system, it's dual work, so on and so forth. And last but not least is the issue of security. How secure is my whole IT infrastructure or ecosystem? That's your data network, that's your connection to the internet, that's your connection from home to the office, it's your sharing of information between one physician and another, say a referring physician and a specialist, or a hospital and a physician office. How secure is all of that? So these are some key questions that if you haven't started asking them, my opinion, our opinion is you really need to. The last slide coming up here is suggested next steps. Continue to learn all you can about MACRA, MIPS, APM. That's why you're on this webinar today. Assess your organization's readiness. Is your staff even aware that this is coming and that it's really here and it's just a question of timing now, rolling this in? Do you really have the data and the reporting requirements understood and defined? Your IT infrastructure, have you assessed that? Have you looked at that to determine the function, reliability, and security? How about your internal workflows? I think you probably have a good sense of where some issues are that need to be addressed in some of these. And do you really have the ability to securely share, aggregate, and report information? Because these are the kind of things that CMS is going to look for in reporting of metrics, and want to be able to have a high degree of confidence that you're reporting these things accurately and timely. Talk with your EMR vendor and other IT vendors. See what they are. Don't settle for, oh, we're working on it and just stay tuned. We're going to have a whole MIPS module or APM module. I would force them and push them to say, no, come here and show me what you're doing. How is this going to help me? What do I need to do now to prepare from your vendor's perspective? And lastly, start now if you haven't, or if you have, keep the momentum going. Create a sense of urgency, but not panic, is my last piece of advice there. So hopefully you get a better sense of some of the implications of IT here. This is very serious. As Max said, data, but it's got to be quality data. You really need to understand to deeper levels of what in your bowels of your organization where this is coming from, why, because it's going to impact everybody's paycheck and reimbursement. So with that, I'll turn it back over to Mac, if I may.
Thank you, Terry, and unfortunately we've come to the end of our hour, so we're going to have to cut short, I'm afraid, our question period. We did get a couple of questions in, though, that maybe we can squeeze in the answers to before we go offline. First question is real quick, and that is, would next generation ACOs be included in the advanced APM model? And the answer to that is yes. Both Track 2 and 3 of the Medicare Shared Savings Program, as well as next generation ACOs, do qualify as advanced APMs. The second question, which I'll ask Max if he can address quickly, and that is, for those that employ an outside billing service, Max, these changes will seem particularly complicated. Can you elaborate on what the new business model might look like for those that have a third-party biller?
I think, yeah, Mac, and I appreciate that question. Thanks for giving me the hardest question of the day. But actually, it's an excellent question, and it probably warrants at least a portion of another webinar. It's that interesting or complex. We went through this a few years ago with capitation, and frankly, I think it was easier then than it will be now, unfortunately. Without any question, we're going to be dealing with a hybrid system where there's still traditional, if you want to call it that, fee-for-service billing, third-party billing, and then as the private insurers and go more and more to bundles and shared savings and different forms of reimbursement, it will be incumbent upon the third-party billing companies, and quite frankly, it'll be incumbent upon the in-house billing offices of hospitals and medical groups to be able to understand and sort through these differentials. So quite honestly, there's no leakage in terms of what's billed. So first of all, and again, time won't allow a detailed answer, but first of all, it's going to require a very clear understanding of what the entity for whom you are billing, since the question was a third-party billing company, actually has contractually, and what their non-fee-for-service contractual allowances and stipulations are, because you can't bill for something that you don't, if you don't understand what it is you're billing for. You know, obviously trite statement, but it's very much the case. And then I think secondly, it will be a staff that can accommodate the different forms of billing in terms of understanding, but to Terry's point, it will require a practice management billing system that can also be malleable and accomplish varied forms of interpretation on how to bill for something other than fee-for-service. And I think finally, it's going to require really good documentation starting at the provider themselves, the physician, the mid-level, APP, etc., to be able then to interpret how the actual dollars would be billed and what they would be. I think to the extent that we're part of shared savings programs, the heavy lifting of what to bill and how and what the results may be would prospectively be done by that entity that's overseeing and managing the shared savings program, whether it's the CIN or what have you. So in that respect, it may be a relatively easy thing for the third-party billing company to effectuate, because effectively it's being done by the manager of that shared services program. And such could also be the case for the bundle. Because remember, if we're talking about a bundle like my example of the OB delivery, normal delivery, you're going to really have several players involved. So the third-party billing company that today is only billing for the practice, the ambulatory professional fee side, is now, at least under a bundled arrangement, potentially either not going to bill at all for that bundle, it would be done by the hospital, or it would be enlisted with that responsibility, but yet would have to somehow have all the information and data in order to bill for everybody. So it's really an interesting and intriguing thing, and I think it will provide a great deal of opportunity for third-party billing companies. So if any of you all are on the line, I think you can look at the glass being half full, not empty. I think it will provide new opportunities. Will it entail more cost, more effort to do the billing? Yes, I think so. So I'll just leave the answer to that question at that for now, Mac, but clearly we'll want to get into that to a greater degree with one of our subsequent MACRA webinars.
Well, thank you, Max, and appreciate you handling that curveball like the excellent baseball player you are, and I think that was wonderful. So speaking of other webinars and other information offerings, would like to ask Savannah to close us out here and tell you a little bit about that, and hopefully we will have the opportunity to get in front of you all again and continuing to discuss all this change, which is exciting to say the least, challenging also, but something that I think in the end, if done right, can truly bring about some positive changes for the healthcare system. So Savannah, do you want to finish this off here?
Yes, thank you for the presentation, and thank you everyone for joining us for this and for submitting your questions. If you have further questions, since we ran a little bit long, please feel free to email those to me directly, and I'll coordinate getting those to the panelists and getting answers to you. As mentioned in the introduction, if you're interested in a customized presentation specific to your organization, please reach out to me directly and we will get that coordinated. There will be more information on our website about upcoming webinars, so stay tuned for those. They will also be information sent out via email. Again, we would appreciate your feedback on this presentation through the survey as you exit the webinar, and the presentations to this slide presentations will be emailed to you shortly. Thank you for joining us today, and have a wonderful day.